We are actually going to move to our question and answer period, and we've got some fabulous questions. Like, it's just fantastic to see people really engaged, and some really interesting questions have come forward. Okay, well, I'm going to start with the first question. Dave, this question's for you. Why should I sign up for a clinical trial for an experimental drug if my doctor can just prescribe me treatment?
Well, you know, it's a complex question. There are, first of all, I myself was in a clinical trial for a new protocol of interleukin. If you just want something where the outcomes are pretty well known, then go ahead and do that. If you want to explore something where your outcome might be better than anything that's known, you might want to try that. Some people just prefer what they feel is relatively safe. But then consider that the treatment that you're getting, this is an issue of a matter of community. Consider that the treatment that you're getting is only available to you because hundreds of other patients agreed to be in clinical trials. And even patients who agreed to be in clinical trials for things that turned out not to work well. So it is, I mean, it's a serious issue. And as I said, to me, the deepest question is, what are you going to do with the time that you have available? Some people choose to be in clinical trials, some don't. I'm not going to shame anybody who doesn't want to, for heaven's sake. Who am I to tell anybody what to do with their body and their life and their family? So.
Thank you. Okay, the next question is for Dr. Scholey. How damaging is the dye given at the CT scan when you have only one kidney? I've been wondering about this myself.
So typically, one of the big concerns that we have with respect to contrast studies, which are done to image predominantly in vascular studies, is the risk to the kidney. In an individual whose EGFR is above 60, the risk is relatively small and not of a concern. As the risk falls below that, so in individuals particularly whose kidney function based on the EGFR would be less than about 30% of normal, we would tend to want to have them seen ahead of time and to use prophylaxis. So for example, in any individual whose EGFR is less than 30%, or an individual who has diabetes in my practice, I would have them be treated during the time of the contrast study, so that our protocol at the University Health Network is the individual appear a few hours ahead of time for an intravenous solution of sodium bicarbonate and water, and that they be given a medication called N-acetylcysteine at a dose of 600 milligrams twice a day, the day before and the day after the procedure. Even though that's our protocol, I can tell you that this is an evolving field and full of controversy, but I think that in individuals, again, whose EGFR is less than 30 and with or a diagnosis of diabetes, that treatment protocol is safe and is likely to exclude major problems.
Thank you. Okay. The next question is for Dr. Moore. What considerations help make the decision between a partial or a radical nephrectomy? And how extensive should scans be pre-surgery?
So the most important thing is your kidney function up front going into it, and the location of the tumor. And if you only have one kidney, certainly you want to save that one kidney. And the more complex the tumor inside the kidney, the more work it takes to reconstruct that kidney and to preserve it. And so if you look at the competing and risk factors that go into it, so if you have an absolutely normal kidney, you still want to save your kidney. That's the message that we're getting out. But it becomes even more critical for you to save that kidney the less you have, or if you have more competing diseases. And I tried to present to you the risks of dialysis alone. So if you look at the risk of dying on dialysis, it's 10 to 15% per year. And that's far higher than your risk of your cancer. And so you may choose not to do anything, in fact. And if you look at your kidney and the small mass and where it's located, it may influence how you choose your surgery. So Some people, I can think of one patient just the other day. So he says, I went and said, Mr. Smith, we took out your kidney and our plan was not to take it out, but your kidney invaded into the sinus. You have an absolutely normal kidney on the other side. When we looked at it interoperably, and there was a positive margin saying that this was an aggressive kidney, it was high grade. And so the decision was made to take your kidney out. And he said to me, well, I'm glad you did, he says, because I was worried about what you told me about recurrence of the kidney cancer. But it's knowledge, it's balancing knowledge. So what are my risks? And I think that comes into the role in deciding how to manage your kidney and what risks you're willing to accept and to understand those risks. So the whole thing of knowledge and empowerment right off front of this conference is to understand what your risks are. So bottom line is you only have so many nephrons and you want to save those nephrons as best you can, and because you don't know what's going to happen in the future.
Thank you. Diane, this one's for you. What can I do to increase my appetite? So if someone's having a lot of side effects, potentially from medicines that they're on, other things, what can they do?
That's a good question. I wish I had a magic answer for that. You don't...
Not hearing? No.
Yeah, just hold it closer.
Sorry. When you don't have much of an appetite, you obviously don't feel like eating. But I think on the one hand, we tend to eat with our eyes before we actually start to eat. So one strategy you could try is eating small, frequent portions throughout the day. And so they're small enough where it's not off-putting, even though your appetite isn't so good. And so you're eating frequently throughout the day to try and accumulate that nutrition that you need. The other thing you can do is when you're choosing these foods to eat, really go for energy-dense foods. So in my presentation, it was more geared to maintaining a healthy weight. But in this case, if your appetite is low and it's during treatment, this is not the time where you want to be losing weight. So you want to make sure every bite really counts and is full of high-calorie food. So this is the time where you might want to add some butter or margarine to your bread, or choose some high-energy foods like that.
Thank you. Okay, this next question is for Dr. Scholey, and there's two questions that are similar, so I'm just going to bring them together. Do all patients at your center with metastatic renal cell cancer have an initial consultation with a nephrologist as part of the team, or is the referral on a case-by-case basis? And what's the best timing? And so the similar question is how to see a nephrologist to review your individual kidney cancer case, and is that necessary or recommended?
So the practice within our group is not for every patient who has stage 4 chronic kidney disease. I'll come back to that in a second, to see a nephrologist. We typically, our uro-oncologists will send their patients to see us ahead of time when they're seeing a patient whose kidney, in whom the surgery is likely to have a dramatic impact on their level of kidney function. And so that would be an individual who starts off with, and not uncommonly, with stage 4, or that is less than 30% of normal kidney function. And a nephrectomy would render them with considerably less kidney function, and there are implications that are immediate in terms of their long ongoing management. So that's more common. So the lower the kidney function at baseline, the more likely they are to see a nephrologist. Now, exceptions for stage 4, now that new medications are in use, one of the common categories of medications that Dr. Moore showed you, and you'll hear, I think, more about, are the tyrosine kinase inhibitors, or VEGF inhibitors. These have been used a lot in kidney cancer. One of they're designed to impact the ability of a tumor to provide for its blood supply. So a tumor, as it grows, needs to grow blood vessels. And so the medications are designed to inhibit the growth of those blood vessels. The kidney is a very vascular organ, and its normal biology is dependent upon the same processes that cause blood vessels to grow. So if you use a medicine that stops blood vessels from growing, you actually can injure the kidney and cause mild hypertension. Now that injury is in general is well tolerated, but that's a very common case for us to see stage 4 renal cell carcinoma in which tyrosine kinase inhibitors or VEGF inhibitors are being used to follow patients to measure their blood pressure, kidney function, and proteinuria. So very common there, and I would say that would be quite routine.
Thank you. Well, we've received a question on Twitter, so that's kind of cool, since I don't use Twitter. This is for Dave, and how soon will we see the adoption of e-tools connecting patients with healthcare providers and facilitating care delivered virtually?
So it is happening. The telemedicine, telehealth. So in some talks, I go into a deeper discussion of what are what I call the particles of value or the elements of value that get passed between people. Like I've got a need and there's an answer somewhere out there. It might be information, it might be services, and what are the ways that I can connect with those? Well, in the same way that I found my wife online, people are finding doctors, or in some cases actually having a doctor's visit with a sort of a secure Skype-like thing. There's a service called American Well, where, you know, the classic story that they have, it's like a secure medical Skype. You've got a baby with a fever at 2 in the morning, do I need to go to the hospital or not? And you go online and there's a pediatrician on call in the middle of the night, might be in a completely different time zone. And you can have your own regular doctor, but you can also see somebody. You can say with your webcam, you know, look at the baby, what do you think? You can also consult with specialists. They have a new version of that where the physician can call in a specialist in the office. So the barriers of distance and time that used to keep us away from what we need are evolving, coming into being. There are also many services now that we're just barely beginning to have the kinds of friendly websites that will help us gather our medical records and monitor things in real time the way that you can with something like mint.com that will keep track of your bank balances, warn you if you're getting low, and things like that. So that's just beginning to evolve, but it is happening. It's not a someday thing.
So we'll just see more and more of it.
Yeah, but one of the challenges we have is how do we find out about these things? And for me, the best thing to do is have somebody, is to know somebody. It might be somebody within KCC who keeps an eye on these things in social media, because blogs and Google alerts and things like that are the best way to learn about them.
Thank you. So the next question is for Dr. Moore. Complications after kidney removal. Can you talk about that? Lymphocell? I'm not sure if that's a particular complication that somebody's referring to. Are you familiar with that?
So lymphocele is a collection of lymphatic fluid in a balloon. And lymphatic fluid is basically blood without blood cells. And so blood goes out in your arteries and comes back in your veins, and what weeps out in between in the capillary bed is called lymph. And if a lymph node is lymphadenectomy, removal of lymph nodes, which filters your lymph fluid and has your immune system in it that processes what's inside the lymph, traps tumors, then sometimes you need to have a lymphadenectomy to remove it. And anytime you're having vascular surgery, which kidney surgery is, and you're disrupting the lymphatics, there's a risk of developing a collection of lymph called the lymphocele, so a balloon filled with lymph. The incidence of it is actually quite low in kidney surgery, fortunately, and we don't see a lot of it. We see it more in prosthetic surgery and pelvic surgery, but you can develop lymphoceles, but they're very uncommon. So it'd be less than 5%, and not everybody gets a lymphadenectomy with their cancer surgery. You have to have advanced disease to really warrant it, and there's still controversy around the utility of a lymphadenectomy, so removal of your lymph nodes without disease in it. But again, for advanced disease, you're usually lifting up the vessels. So if you have a tumor thrombus, or you have a big tumor invading it, there's a higher chance to have lymph nodes involved, and there's a lymphadenectomy performed. I hope that answers the question.
Dave?
I'd like to add something brand new to my previous answer. Earlier this month in Holland, a new software tool was introduced called FaceTalk. It sounds like Apple's FaceTime on the iPhone or iPad, but this is different. This is like a secure medical Skype again, except that it's unlike anything else I've ever seen. You can have several people on a consult at the same time, and you can pull up an image, for instance, a scan, and not just show it to other people, but the originating physician can actually pass control of the mouse to a specialist. So it's a really enhanced consult, bringing in a remote expert. So.
Great. Okay, the next question for Dr. Scholey. Proteinuria, why is there a need to pay attention to protein in the urine? Can this damage the kidneys permanently?
The last part again.
Can this damage the kidneys permanently?
So protein in the urine was for many, many years considered to be a marker of injury to the kidney filter. And so that there was felt to be a direct relationship. The more damage there was in the filter, not only was filtration affected, but the leakage of protein from the circulation into the urine also occurred. And that's still true. So that the more damage the filter, the more the proteinuria. So it's a marker of injury, of disease severity. We also know that protein in the urine now actually directly interacts with the processor part of the kidney, the tubules, and that direct interaction leads to fibrosis or scarring and inflammation. And so that proteinuria is both a marker of glomerular filter severity and a contributor to progressive scarring preceded by inflammation. So any maneuver, typically medicines that what we say block the renin-angiotensin system, but for you that would mean drugs like ACE inhibitors or angiotensin receptor blockers. They lower proteinuria and they preserve kidney function. And that preservation is felt to be dominantly linked to the effect of protein on the processor compartment of the kidney.
Thank you. Okay, just getting the okay to go over 5 minutes, so we've got a few more questions. Here's another question also for Dr. Scholey. Does having one healthy kidney necessarily mean a decline in kidney function? I've been told that the other kidney will compensate, but to what extent?
Yeah, so that's an excellent question. In a young, healthy person, we don't think that nephrectomy confers significant risk to their health, to their mortality, or to cardiovascular disease. The reason we actually, in fact, just up the street at the University Health Network, about 100 times a year, we take a kidney out of a completely healthy individual and transplant it into another individual. So that nephrectomy, taking out one kidney in a healthy person, is unlikely to confer significant risk. Now, that's for a young person age 40 and below. As we get older, you saw from Dr. Moore's graph that kidney function declines, so that we become increasingly dependent on the function of both kidneys, so that risk may be somewhat age-related. Interestingly, there's a biological response that we call compensatory hypertrophy and hyperfiltration. Well, what does that mean? It means when you take out one kidney, or said another way, when you reduce nephron mass, kidney mass, the other kidney somehow and still mysteriously senses that, and it grows. So the remaining kidney grows and it increases its filtration rate. So if I do a nephrectomy in a 35-year-old young person, that kidney will increase its function by about 50%. So they won't be left with half their kidney function, they'll be left with about 75 or 80% of normal kidney function, based on the increased ability of that remaining kidney to compensate. Now, there are many determinants of that response. One of the most important is age. So as we all get older, our kidney's ability to compensate for a reduction in nephron mass becomes progressively compromised. So that if I saw someone in clinic who was 70 years old and undergoing a nephrectomy, I would expect to see less than the compensation that I saw in the 35-year-old. Sometimes it's difficult to predict and only time will tell. There are other determinants, of course, the biggest one being other comorbidities. What I mean by that, an individual with long-standing hypertension or diabetes or chronic kidney disease due to any other cause will be less able to compensate for that reduction in nephron mass. So nature has built in some protection for us. And we take advantage of that on kidney transplant services, and we are thankful for that in individuals who have to undergo a human nephrectomy.
So just on that vein, we do have one question that is asking, what is the normal GFR for somebody who has 2 kidneys, so a normal person, and then what would it, and then for somebody with renal cell carcinoma and has 1 kidney?
Okay, so let's take a 50-year-old individual who has normal kidney function. And that means their GFR is about 100 mils per minute per day. And we take out one of their kidneys. Each of the kidneys is contributing function equally. So one way of thinking of that 100 mils per minute, that eGFR, is that 50 from one kidney, 50 from the other. We do the nephrectomy and we immediately reduce the patient's overall kidney function to 50 mils per minute, or half of normal. But that kidney responds and it increases its function, and that function will end up anywhere between 60 and 70 mils per minute. Again, that rise above 50 in that individual will be dependent on their age. So they will see. So actually, one of the interesting things is we take people who do have a nephrectomy and we look at the serum creatinine, and we can't tell a month, 2 months later that they had a nephrectomy, because the serum creatinine on its own is not a good, not a sensitive enough measure of kidney function. So actually, the compensation keeps their serum creatinine in the normal range. And I would venture to say that within this group, there are individuals who've had a nephrectomy and yet still have a serum creatinine within the normal range. I can tell you that your kidney function isn't absolutely normal, but the compensation has allowed you to remain within the normal range for serum creatinine.
Thank you. Yeah.
So in the normal range for serum creatinine, it would be typically between 70 and 110 micromoles per liter.
Well, you know, those are great questions, and thank you very much.